Okay. شكرا جزيلا الفرصة ان انا address الكونفرنس. Thank you for the organizers. الأستاذة الدكتورة منى أمين specifically يعني دينامو المؤتمر. Thank you very much for inviting me to be amongst my professors and my friends. I was asked to answer this query in under 15 minutes, optimizing the perioperative care of cirrhotic patients. Now, the operative risk in cirrhotic patients, the surgical risk depends على 3 حاجات. The severity of the liver disease, the nature of the surgical procedure, and the presence of other comorbid conditions. المثلث ده هو اللي هيحدد إجابة السؤال. أول حاجة الليفر cirrhotic liver has a problem of decreased liver perfusion. There is decreased both portovenous perfusion as well as arterial hepatic perfusion in patients with cirrhosis. This is due to portal hypertension offering resistance to blood flow, as well as increased cardiac output due to peripheral vasodilatation and arteriovenous shunting. So the liver is not getting enough blood. That's the first point. Decreased perfusion at baseline makes cirrhotic liver more susceptible to hypoxemia and hypotension in the operating room. We all know that many of the drugs giving and the interventions done in OR during surgery would cause both hypotension and hypoxemia. So this will further decrease the perfusion of the liver more. The anesthetic agents, for example, reduce the hepatic blood flow by 30 to 50%. That's why we ask our anesthesiologist to use specific anesthetic agents like the isoflurane and the sevoflurane, for example, because they are less harmful to arterial blood flow and they are the preferred agents for anesthesia in cirrhotic patients. Now, what are the additional factors that make the blood flow to the liver less? The hypotension, the hemorrhage, the vasoactive drugs that sometimes we need during surgery, intermittent positive pressure ventilation and pneumoperitoneum done during laparoscopic procedures, which is, I think now nobody does open surgery anymore except rarely. Traction on abdominal VSR would cause reflex vasodilatation in the splenic vein and further decreases the blood flow to the liver. So, the intraoperative hypoxemia or decreased oxygen supply, this is item number 2. So we decrease the blood supply to the liver and then we decrease the oxygen supply to the liver. The hypoxemia is due to ascites, hepatic hydrothorax, hepatopulmonary syndrome, and portopulmonary hypertension. Now, these must be treated and managed properly, preoperatively, before the patient is exposed to surgery. The third item is the muscle relaxants and narcotics used during surgery. Now, when we give muscle relaxants, especially the non-depolarizing muscle relaxants, they are diluted in a much larger volume of fluid because cirrhotic patients retain fluid. So, unfortunately, we need to give the patients higher doses of muscle relaxants to achieve proper neuromuscular blockage. Otherwise, the patients would start jerking and moving during surgery. Now, the atracurium or the trachurium, as the trade name commonly known to us, are considered the preferred muscle relaxants because they do not depend that much on liver or kidney elimination. So I can give them even if the liver functions are a bit compromised and the kidney functions are a bit compromised as well. If I need long-acting muscle relaxant, the doxacurium is the preferred one. Now, sedatives, as a general rule, sedatives and narcotics and the IV induction agents are generally tolerated in patients with compensated cirrhosis. But we must be very careful when we give them to a patient with a liver dysfunction because they may cause precipitation of hepatic encephalopathy and prolonged depression of the conscious level, and the patients would take much longer waking up after the surgery. Benzodiazepines and narcotics should be avoided as much as possible. When absolutely necessary, we have to use specific agents like the oxazepam, for an example, because their metabolism by the liver is minimal. And now, there are Absolute contraindications to elective surgery. If these are present, then we should not contemplate elective surgery. Acute liver failure. We shouldn't do surgery in somebody with acute liver failure unless it's an emergency life-saving surgery. Acute renal failure, acute viral hepatitis, acute alcoholic hepatitis, cardiomyopathy, severe hypoxemia, and severe coagulopathy, which cannot be corrected using vitamin K. So these are contraindications to surgery. Now, we need to address the issue of the severity of the liver disease. We have several scoring systems that we can use to assess the severity of the liver disease. The most famous is the CTP score or the Child-Pugh score, which was invented back in the 60s and early 70s. It comprised 5 parameters: bilirubin, albumin, prothrombin, encephalopathy, and ascites. And the patients were graded in a point scoring system and then classified into A, B, and C according to the severity of their liver disease. This child classification helps us to predict the perioperative mortality, and it correlates with the frequency of postoperative complications. And that is why the child score was invented. It was actually to assess mortality, postoperative mortality. Now, as a general consensus, elective surgery is usually well tolerated in child A patients and contraindicated in child C patients. What about the middle ground? What about child B patients? Elective surgery is permissible, but with proper preoperative preparation of the patients, correction of all the other risk factors, optimizing the performance of the patient before sending him to surgery. The 2 exceptions are extensive hepatic resection and cardiac surgery. These are usually not very permissible in child B patients. So child A, it's okay. Child C, it's not. And child B, just optimize the patient first. Now, over time, the limitations of the Child-Pugh scoring system were exposed, and another score came by. That's the MELD score. It was initially developed by the Mayo Clinic, and it avoided the limitations of the child score, which is the objectivity of the score. In child score, we assess 2 items, encephalopathy and ascites, and these are clinical assessments, which give chance for error. So the MELD score depends on numbers. It depends on the bilirubin, on the creatinine, and the the need for renal dialysis, as well as the INR. So the patient is assigned a score. The MELD score usually associates with mortality, where a MELD score of less than 9 is related to under 4% mortality over 3 months. When the MELD score rises to reach 10 to 19 points, the mortality jumps to 20%. When the MELD score rises to 29, the mortality jumps to 45%. And if the MELD score is more than 40, unfortunately, the 3-month mortality rate is 70 up to 100%, which is exceptionally high. MELD score was used for many years to stratify or to prioritize patients on the transplant list, to say which patient is in need of a liver transplant more and should be giving the organ before the others. Of course, it's not very applicable in Egypt because we're not using orthotopic liver transplant. We're using living donor liver transplant. Now, with MELD score, each 1 point increase in the MELD score makes an incremental contribution to the operative mortality risk. It was shown in a retrospective study that a 1% increase in mortality was associated with an increase in MELD score from 5 to 20%. And that 2% increase in mortality for each 1 point above 20. So if the score is 21, the mortality increases 2%. If the score is 22, the mortality increases 4%. If it's 23, the mortality increases 3%, and so on and so forth. And here we can see the regression curves. This is for the 30-day mortality, the top curve, and the bottom curve is for the 90-day mortality. And we can see a linear correlation. As the MELD score increases, the mortality increases in a linear fashion. Now, again, there were limitations with the MELD score, so the MELD sodium score was developed, and here is the equation that we used to calculate the MELD sodium score. For a good number of years, the MELD score was the go-to method for, again, prioritizing the patients in liver transplant lists. And then 2 or 3 years ago, the MELD-3 score came up, which, again, is different. We can see here that the initial MELD score had the criteria of bilirubin, INR, and creatinine. The MELD sodium added sodium to that. The MELD-3 added bilirubin, okay? Bilirubin and albumin. These are two functions of the liver. One is detoxifying or conjugating and excreting function, and the other one is a synthetic function of the liver. So it's supposed to be more representative of the true liver status of our patients. Now, these are the risk factors in patients with cirrhosis who undergo surgery. There are things in the patient and things in the surgery itself. So patient characteristics are the presence of anemia, ascites, the Child-Pugh score, the MELD score, the presence of encephalopathy, hypoalbuminemia, hypoxemia, presence of active ongoing infection, malnutrition, portal hypertension, and prolonged INR. The factors in the surgery are the type of the surgery. Cardiac surgery is associated with a higher risk. Emergency surgery is associated with a higher risk. Hepatic resection has a very high risk, and open abdominal surgery as well. So these 4 types of surgery are associated with higher risk of mortality and morbidity. Now, we can see here the mortality rates as assessed by the child class and the MELD score. One example that stands out, and I chose to highlight in red, is the major abdominal surgeries. We can see if we did the surgery in a child A patients, the mortality risk is only 10%. In child B, it jumps to 30%. In child C patient, it jumps all the way between 75 and 82%, which is very unacceptable. Now, we should also look at the ASA classification of the patients. The ASA classification is a score that anesthesiologists use. The American Society of Anesthesiology developed this score where it's not specific for liver patients, it's for any patient going into surgery. The patient is giving an ASA class of either 1, 2, 3, 4, 5, or 6. 1 is a very healthy individual, and 6 is a brain-dead individual. The other 4 scores are somewhere in between. So it's very important to calculate the ASA class of the patient. Why is that? Because an ASA class of 4 adds the equivalent of 5.5 MELD points to the patient. So as if I'm increasing the MELD score of the patient by 5.5 points. And we know that 5.5 is associated with times 2 risk of mortality. So I'm increasing the risk of mortality by 11%. Okay, what about class 5 patients? Class 5 patients, as a class 5 patients, has almost 100% mortality rate. So I wouldn't recommend surgery in them. Now, this is a very beneficial web link that maybe our residents and registrars should try and visit. This is a link for the online Mayo Clinic calculator. It asks you to input certain information, and at the end, it gives you the expected mortality scores. And I recommend it to all our juniors. Okay, so post-operative monitoring is really important. We monitor for signs of liver decompensation, including encephalopathy and coagulation, defects, ascites, jaundice, or renal dysfunction. Prothrombin is the best and fastest indicator of hepatic synthetic dysfunction post-operatively, and elevated serum bilirubin doesn't always mean liver dysfunction. It could be related to a hematoma, for an example, or related to hemolysis. So we have to be careful about that. Okay? Hypoglycemia is frequent, especially with acute liver failure, And assessment of intravascular volume is really important. We shouldn't neglect the patient and allow him to go into either hypo or hyperperfusion. Hypoperfusion worsens the liver function, of course. Hyperperfusion is again a problem. Giving too much fluid is a problem because it causes acute hepatic congestion, pulmonary edema, tense ascites, and wound dehiscence. So this is my final slide. This is the answer to the question I was giving. What is the optimum perioperative care of cirrhotic patients? It must include first the assessment and grading of severity of liver disease, avoiding the absolute contraindications to surgery, looking for and correcting the confounding risk factors prior to surgery, choosing the proper anesthetic agents, the proper muscle relaxant, the proper sedative, and the proper narcotic agents, avoiding intraoperative events that can negatively impact the liver, like hypotension during surgery or bleeding. And finally, close post-operative monitoring for any signs of decompensation and managing it in a timely manner. Thank you very much.